Good morning and welcome to today's webcast, Patient Safety Awareness Week, Improve Patient Safety Through Lean. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm pleased to introduce today's presenters, Dahlia Mack, MHA, and Andrea L. Halliday, MD. Dahlia is a managing director within the Lean Healthcare practice at Moss Adams. She has worked in the healthcare industry for more than 20 years, specializing in operations, patient safety, quality improvement, and risk management. A graduate of the University of Washington and the University of Southern California, Dahlia has a number of professional certifications and specialized training in Lean, which she has practiced since 2002. Dr. Halliday is an accomplished neurosurgeon specializing in the treatment of spine disease. After a career in academia and private practice, Dr. Halliday joined PeaceHealth, where she leads quality and patient safety programs in her roles as System Chief Clinical Officer and Oregon Network Chief Medical Officer. She is a graduate of Harvard Medical School and completed her residency in neurosurgery at Massachusetts General Hospital and a fellowship in reconstructive and complex spine surgery at the University of New Mexico. And with that, I'll turn it over to Dahlia to get us started.
Thank you, Emily. And I'd like to extend a warm welcome to our attendees for joining us today. We deliberately scheduled this webcast during this particular week, which was created to heighten awareness and learning about patient safety. Patient safety is everyone's work. We know that patients entrust us to provide high-quality care and not harm them in the process. We also know, however, that our systems and our processes are not consistently delivering conditions to prevent harm. We will share with you today some ideas and examples of Lean application for you to consider what you might do differently within your organization. We're very honored to have a special guest, Dr. Halliday, with us today to share about some of the clinical excellence improvement work at PeaceHealth. This will include highlighting their development and deployment of a safety stop process across their system and steps they've taken to enhance their organization's safety culture. We will also spend some time addressing how Lean applies to some of our latest current events with coronavirus preparation and management. The topics that we'll cover today are really about patient safety and culture, Lean in healthcare, the patient safety stop, and what we can do to keep patient safety at the forefront each and every day. So as we start off in this area, we want to first address that patient safety is all about focusing on patients making healthcare safer. And this really spans the entire care continuum and involves everyone, everywhere, and every time. It's about empowering everyone to be quality and patient safety inspectors. Whether you are a frontline caregiver or an environmental service team member disinfecting and helping to turn over rooms, everyone can take steps to do their work in ensuring patients receive the best quality of care. It's about recognizing that our patients seek care across multiple settings and along the care continuum, whether it's the ED, perioperative services, hospital, clinic, or other locations. And we need to manage these transitions in care and provide good instructions to reduce readmissions, open up access, and make sure that patients receive what they need. It's also about effectively ensuring safe conditions for patients to receive care each and every time and equipping our healthcare team with the essentials that they need to do their work. And finally, it's about learning what's not working, what could be better, and then taking steps to reduce and ultimately prevent harm. From the Institute of Medicine report in the 1990s, we know that medical error is a source of patient harm. We have focused greater attention to improvement in this particular area, and we've seen 50% improvement in patient safety measures, 17% reduction in hospital-acquired conditions, fewer patient deaths, yet we recognize that we still have much more to do. Determining the exact cost of poor quality is not easy to do because we often have hidden waste, things that we just simply don't know about that our team members are doing in terms of workarounds and managing interruptions, defects, and delays. I would suggest that we have some indicators in the form of patient safety events, professional liability claims, non-payment for these types of events, but that we don't really know the true cost of poor quality. Why? We have breakdowns in communication, equipment failures, lots of firefighting, production pressures, and workarounds that create defects and delays in care. And energy is often diverted to address those particular broken systems, processes, instead of ensuring that we are really focusing on value-added and patient care activities. So despite our best efforts, we don't know what might be getting in the way. We also have challenges with really understanding what is happening because of some recent reports that indicate that one of the main reasons why staff don't report is because they begin to normalize defects and delays in their current state. And safety events can have significant impact on patients, clinicians, and many more. And discovering defects too late can cause great harm, be frustrating, and are sometimes really devastating to patients, doctors, and the team. We know that diagnostic errors, whether they're missed, delayed, or undiagnosed, can be fatal and or life-changing, and providers can become second victims, start second-guessing their clinical skills, and possibly leave the field altogether. Clinician burnout, poorly handled communication and resolution, and the simple experience of medical error can result in emotional harm, resulting in patients not seeking care after their safety event. Any one of these things could be a webcast on their own. However, we will focus on a few particular areas today. I just wanted to take a moment at this time to address coronavirus. As we originally planned for this webcast, COVID-19 was not in the picture. Recognizing that this is something everyone can identify with these days, we wanted to address what it's doing to our healthcare systems. Despite our best efforts in emergency preparedness, planning, and our existing symptoms, many of us are feeling uneasy about how to prepare for and manage this situation. This global health challenge has, without question, created urgency and some would say an unprecedented set of conditions for us to address. Addressing this particular situation truly requires leadership and an all-hands-on-deck approach. Standards and guidance from CDC and public health have been fluid, making it difficult to land on standard work or the most reliable way that we need to perform our work processes to deliver the performance that we expect. It requires clarity and flexibility to adapt to changing conditions. And if you don't have daily management and systems in place, then you might be scrambling If you do have key processes ready to go and a culture of continuous improvement, you are better prepared. A lean approach can help to address this by reducing time to understand what gaps you have, what you need to close them, whether it's in the clinical areas, incident command, or supply management. Processes can be made clear, and you could create visual systems that make it easy to see the status of what metrics you need to have to track your meaningful and relevant processes. So, Emily, we have our first question at this particular time.
Okay, our first polling question. How comfortable are you with your organization's patient safety strategy and practices? And your options are A, very, we have a good system in place. B, somewhat, we have a system, but we are seeing mixed results. C, not really, we have a system, but we are just getting started, progress is low. D, not at all, we don't have a safety strategy in place. And I'll give everyone a few moments to respond. To participate in our polls today, please click the button next to the answer you choose and hit submit. And we'll give everyone a few more seconds on this first poll. And let's go ahead and take a look at the results. Dahlia, back to you.
All right, thank you. Thank you, everyone, for responding. It looks like about 46% of you feel like you have a very good system in place, but that we have some others who are feeling like, well, we have some opportunities. So in our next segment, we're going to explore how lean is a better way in healthcare to addressing defects and errors and to really build upon the two pillars of continuous improvement and respect for people. So with lean, we have the ability to improve healthcare, and lean provides tools and the methods and strategy for substantially reducing wasteful operations that create poor quality and obstruct flow. The Toyota Way House here displays the underlying philosophy of Toyota's management system. At the foundation, we have challenge for the current state. We have Kaizen, or continuous improvement, Genshi Genbutsu, which is really about going and seeing the work where it occurs, respect for people and for the community, and teamwork, recognizing that healthcare is really a team sport and that we all need to work together to deliver our processes. And we have these two pillars of continuous improvement and respect for people that represent the core practices. So while this was created for the manufacturing, it really does emphasize the elimination of waste and really focus on improving value for the customer, which can apply to healthcare. As we see in this next slide, the essence of lean healthcare is depicted here. I'm going to walk through this briefly with you. In the top section, we have the impact of 60% or sometimes greater improvement in areas such as productivity, defects, and lead time with the application of lean. There are 7 interconnected flows of healthcare which we want to improve. They're patients, providers, medication, supplies, information, equipment, and instruments. And we also recognize that there is waste, which impacts our customer and staff experience. So we want to be addressing overproduction, waiting, transportation, processing, overprocessing, and inventory, movement, and defects. So we need to seek to progressively eliminate waste and variability to create better value and reduce cost. It's simply not good enough to reduce waste. We have to get rid of it because it usually multiplies. So for example, defects with not having source documentation indicating which side of a patient's body needs to be having the procedure can be compounded with the team moving to proceed and could result in wrong site surgery. Ultimately, the outcomes from lean healthcare are shown here at the bottom, which are higher quality and safety, patient satisfaction, lower costs, and higher profits. And that is truly the essence of lean in healthcare. So how effective is lean in healthcare and how long has it been around? Many of you probably already know this, that lean was introduced in healthcare about 20 years ago. And there is some research that has been done by UC Berkeley, which has been studying its effectiveness. Clear research shows that it works. And in particular, I'd like to highlight that on the right side here, we have seen that we have achieved lower death rates for surgical patients, lower unplanned readmissions rates, higher HCAP scores, lower Medicare spending per beneficiary, and higher EBITDA margin and higher margins in general. So as we look at systems defects, Safety events occur with any number of inputs, and we often struggle with problem solving because we don't know where to start. What problem are we trying to solve really should be your starting point, as well as understanding how the work is done in the place where it occurs and what gaps and waste exist. A3 thinking is something that could provide structure and focus. It follows the scientific method of plan, do, check, act. And at Toyota, it evolved to become the standard format for problem solving, and it provides a basic framework for understanding a problem, the targets, why the problems are occurring, countermeasures that could be taken, and an implementation plan as well as a follow-up. So in particular, as we think about an example of specimen management, through safety reporting, an organization started to see a trend of lost specimens that could delay diagnosis and treatment or create the potential for inaccurate care for patients. Identifying how frequently this occurred was not easy, but data collection and observation in the workplace led to a decision to have an improvement event to mistake-proof the specimen management process. Their specific target was to get to 0 defects. They wanted to make sure that 100% of items that were removed from patients during surgical procedures were properly identified, and then moved on to the next process for pathology to perform their work. We first assembled a team to get clear on the problem and help with the improvement work. This required observations, which then really helped us illuminate the waste in the processes. The frontline caregivers who were involved in studying the process went from, I think I know what happens, to I know because I directly saw specimen communication, documentation breakdowns, I saw variation, and I also saw that we didn't really have a standard process in place. So the root cause analysis process then was performed, and staff ultimately came together to create standard work and tools to facilitate clarity amongst their team for proper identification, removal, and handling of specimens. They then did some testing to see how those would work and tested specifically within a particular area of surgery to achieve 0 defects before rolling out to the entire department. And they were constantly checking to see, to make sure that there was enough training and observation of the new process to ensure that it was working well. So Emily, I believe it's time for our next question.
All right, our second polling question. When it comes to safety, what is your biggest concern? And your options are A, coronavirus prep and or management of other outbreaks, B, safety event reporting response, C, high numbers of serious safety events and hospital-acquired infections, D, diagnostic error, E, medication safety, or F, other. And if you are selecting other, and you may enter your options in the Q&A if you select other. As a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And we're on our second question. And let's go ahead and see what everyone has to say. Back to you.
All right, thank you very much for your responses. And I think not surprisingly, everyone has marked coronavirus preparation and management as a concern. And we will actually move on to the next section and continue to look at how some of these practices could help. So we'll take a look at building a culture of safety in this next segment. Stopping the line is really part of some of the work around building a culture of safety, and there are several key ingredients that are essential to building and sustaining safety culture within our organizations. The 2010 IHI white paper noted that safety culture plays an important role in the safety and quality of patient care. Organizations striving to establish a culture of patient safety are in a better position to deal respectfully with tragic cases when they occur. The organizational culture will enable them to eliminate these events, hear more quickly from patients, family members, and staff about incidents when they occur, and respond with the expectation of respectful communication, disclosure, support, resolution, learning, and improvement. We know that healthcare is complex, that we all have competing priorities, urgent matters to attend to and some challenges with getting information back to teams. And in some cases, we may not even recognize that we have a problem. Building a safety culture requires senior leadership commitment and courage to push beyond current state, to support and maintain a relentless focus on improving systems and processes. It also requires empowering and engaging and celebrating staff for surfacing and reporting near misses, safety events, and problems, and they're coming up with ideas to make things better. Learning from events and making improvements is a key part of building a culture of safety, and practicing humble inquiry and creating psychologically safe situations for crucial conversations is key. So a part of the culture of the Toyota Way is building a culture to stop and fix problems. This had origins in the Toyota factory floor, where workers were empowered to pull a cord or push a button to signal to leadership the need to assess an actual or potential defect, slowing the line to see if the issue could be resolved, or else stop with the intention to not pass on defects. And stopping the line has been implemented in some healthcare organizations, and Andrea will share more about PeaceHealth's experience. Building quality into every step. We know that it's important to build quality into every step of a process. This is true because the cost to our patients as well as to our organizations of poor quality grows exponentially by a factor of 10 or more as defects travel away from their source. More often than not, in healthcare, we must rely on our healthcare teams to have the discipline to stop the process. Thus, the emphasis on building the right culture is even more important in healthcare. We have to make it safe for people to stop the line, to speak up, so we can identify and work towards addressing unsafe practices and conditions. As we think about fostering transparency and psychological safety, how do you create an environment so that every person at every level is comfortable with speaking up? What can you do to promote learning within your organization where there may be fear of blame? What can you do to begin to examine what went wrong? And how do you learn from near misses and safety events to create systems for further improvement? Defects are likely to be produced when conditions for producing a product or service correctly are not in place. Rather than finding and correcting defects after they've been created, we can focus on creating conditions that make it easier to do things right. Some of this involves engaging our frontline to be safety inspectors, for them to identify, stop, and fix problems as they surface in the moment, and to help us with tackling bigger, more complex problems. They, however, need space, guidance, and protected time to do this. And we also need to move away from a blame and fear environment to really thinking and asking people for doing what they are doing every single day to stop and fix and keep our patients safe. When we think about how do we create sort of the focus around this approach, who do you need and what is required, we have to get everybody involved in everyday improvement, celebrate patient safety, and practice just culture, and really work on championing and sharing lessons learned. Emily, I believe it's time for our next question.
Okay, our third polling question: how do you learn about your safety culture from your staff? And your options are A, we annually survey and use those results to make improvements. B, we annually survey, but we only review the feedback, and we don't find it helpful to make large-scale improvements. C, we survey infrequently. D, we don't survey, but we have other ways to ask staff about their practices. Or E, we don't seek input from staff about safety. And for those of you that would like a copy of today's slide deck, you can download them now from the folder that says slide deck and handout to the right of the slide view. We will also be sending the slides via email after the webcast. And let's go ahead and see what everyone has to say. Dahlia, back to you.
All right, so thank you. It looks like most of our attendees are actually surveying annually and working to put those improvements in place, and that we have a number of our participants on today's call who don't survey but have other ways of asking about practices that are in place. Okay. Thank you. Well, I'd like to turn it over at this particular time to Dr. Halliday to share about the PeaceHealth Safety Stop story.
Thank you, Dahlia. So first of all, I'd like to extend my gratitude to Moss Adams, and in particular to Dahlia, who really helped us on this journey. All of our value streams and our Kaizen workshops that we use to develop our safety stop process were supported by Moss Adams, and we're very grateful for that. So I'll just tell you a little bit about PeaceHealth. We are a healthcare organization that serves the Pacific Northwest. So we have clinics and hospitals in Alaska, northern Washington, southern Washington, and central Oregon. We're a Catholic organization. We're started by the Sister St. Joseph of Peace, and we have 139 clinics in our medical group, have 3 level 2 trauma centers, have 16,000 caregivers, and over 1,100 employed physicians. We have 10 hospitals, and 5 of them are critical access hospitals. So why did we embark on this work, and why now? We looked at how long it took from the time a safety event occurred to the time we learned about the event to the time we decided what kind of improvement we were going to do as a result of the event. And if we decided to do an RCA, it could be weeks later before we actually convened the RCA. And then we had several steps involved in the process to approve the action plan that came out of the RCA. And then we had a process, we also then were implementing and then validating that we had implemented what we said we were going to implement as a result of the RCA. But amazingly enough, when we looked at cases evenly distributed between our critical access hospitals, our acute care hospitals, and our clinics, because we did this throughout our entire healthcare system, we found that in all situations, it took us about 9 months. And the defect rate was also 85%, meaning that only 15% of the time could we verify that we had actually implemented and validated what we implemented to be effective as a result of a serious safety event. So this was very sobering to us, and it wasn't in keeping with a new commitment that a lot of healthcare systems have gone to of 100% perfect care, zero harm. We did not feel this was in keeping to the mission of our organization, and it wasn't really what our patients or families would expect of us. So we decided to redefine the possible to better serve our patients and communities and really commit to clinical excellence and developing and implementing systems that achieve 100% perfect care, zero harm. And our safety stop process, we feel, is one of those systems. We, of course, did this from the point of view of a just culture, understanding that to err is human, and that really the responsibility of the organization is to design systems that prevent human error from reaching the patient. So this also coincided to a recommitment to our lean journey. Now, we've had a very circuitous relationship with lean, as is diagrammed here. In the lower left-hand corner, what you can see is Sister Monica. So Sister Monica was the first healthcare executive to go to a Toyota plant to look at the Toyota production system, and she brought that back to PeaceHealth. And we were on that journey for a while, and then we developed a closer relationship with Intermountain Healthcare. And then we had a lot of diversity in our lean approach across our system. We really tried to operationalize a daily management system between 213 and 216. And then 2017, we really committed to a lean transformation. And part of this, because it was also coinciding with our feeling we weren't living up to our mission with our response to serious safety events, was to use patient safety as and our response to serious safety events as our first value stream. So our approach was we basically looked at these, the records I showed you, and we basically figured out how long it took between each steps, and we matched out each steps. We brought people from across the system to do this, but we also had, since it's very important to go to the Gemba, and we also had people in each one of our ministries that could go and see and verify whether or not something was in place that had come out of an action plan from a serious safety event. So when we did this, we developed what you can see in the background is a value stream map with many, many, many processes. And what you're seeing on top of the value stream map is a waste wheel. So all the yellow stickies that you see underneath the processes, they help delineate where we had waste. As you can see, we had a lot of waste in the process, a lot of over-processing, a lot of waiting, multiple steps with multiple waiting in between the steps, and a lot of defects. And the reason that a lot of this occurred is we did not have the operational ownership we needed at the highest levels to have a lean process. And that was one of the huge realizations that came out of the value stream. The other thing that came out of the value stream is if you looked at the front part of our value stream process, we realized we could cut out multiple steps if we had an immediate response to a safety event. So we decided to redefine the possible, and we basically took all the steps and we decided to fix our defects, eliminate unnecessary steps, combine, co-locate, and coordinate where possible, rearrange and resequence some of the things we did, and primarily simplify and standardize our process. By doing that, we came up with future state targets. So instead of a 9-month lead time, we committed to a 1-month lead time, where we would, by the time an event occurred, to the time we had an action plan that had been implemented and verified, that would be a month. We also committed to 0 repeat serious safety events across the system by April 2019. We have not achieved this, but we're working on this very hard, with the thought that if we implemented and verified that what we implemented was working and then spread that across our system, we would decrease repeat events. We also had a target of improving our culture of safety, which we achieved by July 2018. So there are key features that came from the safety stop process, and that we would call a safety stop upon discovery of the event. So no more putting in a variance report and then waiting for somebody to look at it and waiting for somebody to say, oh my gosh, we need to address this, and then it goes to some committee to address, that there would be a safety stop called on discovery. We also said that any caregiver can call a safety stop. We committed to an immediate response, which means in our hospitals that a house coordinator or a house supervisor responds, and then we subsequently have a team of an administrator on call and a safety stop responder to come start doing the interviews right away, sequestering any equipment that we need to sequester, and then also to help implement countermeasures, which I'll talk more about in a bit. In our clinics, we have a designated administrator on call and the manager. They're also the secondary response team. We committed to having a root cause analysis if we decided to do a root cause analysis based on the event within 72 hours. That we would implement the action plan within 10 days of the root cause analysis and verify that the implementation had actually occurred and validate that it was accomplishing what we intended it to accomplish within 20 days of implementation. We also have a closure huddle where we go back and close the event with the frontline staff and thank them for calling the safety stop and for all the improvement work. And then we are committed to spreading this across the system, which is something we are still working on. We do for the most part, but we are still working on processes that will make that more reliable. So the other thing I should say that as a result of this future state, we increased our value add to 49%. That means almost 50% of the work that is done in this process is value added from the patient's perspective. Our original process was 1.5% value added. So the future state is improved response and management of safety concerns. The trigger for calling a safety stop are the NQF never events, but also any potential threat to patient safety. So we see safety stops called far more for close calls than we do for events of patient harm, which is, of course, what we want. We committed to reduce lead time, to eliminating waste, and to implementing immediate countermeasures. So that's why we have the team come in. So, for example, if we have a medication that is stocked in the PICSIS incorrectly, the team can identify that problem. They then can go, some members can go to the pharmacy and try to understand that happen, while other members go and check every PICSIS in the hospital to make sure that same error has occurred. We do not want to leave the scene of a safety stop until we know that we have implemented something that will keep the next patient safe. So what is safety stop? Again, all caregivers and providers are empowered to stop the line. When we initially rolled this out, there was some concern from providers that this would just be another way of staff, quote-unquote, tattling on them. But we have as many providers calling safety stops now as we do caregivers. This has been embraced throughout our entire organization. We've committed to immediate leadership support. So we have leaders coming in who can help mobilize needed resources. We identify countermeasures and implement them right away. And if the prioritization indicates, we have a root cause analysis. So this was all done based on concepts of lean and the Toyota management system and with the help of Moss Adams. So our timeline, we ended up implementing this. We started, we had our value stream in October 2017, the end of October, early November. We actually had some pilot sites implement with the first part of the safety stop process in January. And then we basically implemented it throughout our entire system. And the stop signs above are showing you the times of implementation. This goes out through actually March of 2019, our last implementation with our home health. So we've implemented in home health and hospice as well. And these are example of the Kaizens. We had to do some copycat Kaizens, which I'll talk about in a bit, in the sense that not the process that we developed for the acute care hospital wasn't necessarily, all of it wasn't necessarily going to fit for our critical access hospitals, all our clinics. We developed standard work for all our roles, which are easily accessible for all caregivers so that they know where they can access the standard work, and it has any role of anybody involved in a safety stop has standard work to follow. We then have tools to guide the work, and the safety stop checklist has been key to make sure that we don't forget to take care of the caregiver, call risk when we need to, get the chaplains involved when we need to, report anything that we need to, and make sure that we have all the names and phone numbers of caregivers that we may be asking to attend an RCA. We use a prioritization tool, and this tool is used the day following, or it can be the same day of the event, depending upon when the event occurs, and that helps us determine whether or not we're going to do an RCA. So we look at how frequently the event is likely to occur and what is the most likely level of harm, and that helps us prioritize the work. So anything that's red gets an RCA. If it's a serious safety event, gets an RCA, but if it's a close call with a high likelihood of occurring and causing harm, then it gets an RCA. If not, it gets it becomes an orange event, and that's tracked at our leadership huddle, where a process owner is assigned, and those things are tracked and followed up. And then we have other levels of process improvement that occur with white and yellow events. So these are our key features, and as we decided that we could make adaptations that would fit a critical access hospital that has different resources, or clinics that has different workflow, we said these are the key features that must be in place. That a safety stop can be called by any caregiver, that there will be an immediate response by someone on site and then followed by a team to come in and start the investigation right away, that we send off a safety stop notice. So we have a notice that goes to leaders to let them know that the safety stop has occurred and what it is about. We have the handoff huddle that I just described to look at the event and gather some more information, get the managers involved at that point, and decide what is going to be the next step in addressing the event. We have system escalation huddles, and the system escalation huddle is if the event involves something like facilities or our supply chain or our electronic medical record, we need system resources to help resolve the problem. So that is a place where events are escalated and also a place where events are shared across the system. We can do a root cause analysis when it's determined by the handoff huddle that that's appropriate. We develop action plans, which again, the action plans are developed at the RCA. We assign an executive sponsor, and this was, again, one of the key moves was getting high enough level operational ownership to make this successful. And so the executive sponsor attends the RCA so that we know, and they approve the action plan. We used to have issues where an action plan would come out of an RCA, and then the executives say, well, we can't do that. So this is a way of avoiding additional steps to develop an action plan and have it approved at the time of the RCA. This is showing closing the loop and developing the thanking of caregivers for calling the safety stop and for engaging in the improvement work. And then we also work on system spread so that lessons learned are shared throughout our healthcare system. There were adaptations, as I mentioned. The critical access hospitals were first saying, well, you know, we don't have house supervisors. We don't have administrators on call. We don't have this, we don't have that. So what we did was we just said, look, this is not something we can solve for you. You're the ones who know your workflow and your resource constraints. And it's a big learning from Lean that the people who are doing the work should design the process. So we brought them all together. It was the first time our leaders and frontline caregivers and managers from our 5 critical access hospitals ever were in the same room together. And we just said, okay, let's talk about what are the characteristics of an administrator in that role. What do they need to be able to do when they respond to a safety stop? And what are the characteristics of a safety stop responder who partners with them, helps provide fresh eyes, helps to start to do the interviews? Who in your community can serve that role? And then we said who's available. And by the time we did that, they all said, we have people who can be in both roles and who we can tap in our community, and we can do this process. We also did an adaptation in the medical group. It turned out that responding right away to a safety stop in a clinic setting could be disruptive. And lots of times the event was something that might have occurred in the past that was just discovered. So a missed referral or a missed follow of a test, and so it's a different situation than the hospital. And so what we do then is we call and we say, we thank you for calling the safety stop. When can we respond and do our investigation? What time during that day, so we can start doing the investigation that we need to do to determine the next steps in terms of solving the problem raised by the safety stop. So where are we now? Well, our culture of safety did improve initially. It has plateaued, and we're addressing that with more deeper embedment of just culture, which we really hadn't done, and also making sure that everyone understands that when a safety stop is called, what we say is thank you. We have addressed an issue. Some people were feeling like, well, this isn't really a safety stop. We could have put in a variance report, or we could have put in a ticket for our EMR, or maybe it's something we could erase for our daily management system. But what we found is all of those escalation pathways were broken. And so caregivers were calling a safety stop because, as one caregiver told me, if you want something to get done, you call a safety stop. So we are now in the process of working on all of our other escalations pathways to make them as effective as our safety stop process. You can see our baseline of event to RCA with an approved action plan was 58.2 days, and we have it down to 4 days. Our event to action plan closure was over 9 months, and that's down to 34 days. We stood up a Tier 1 huddle, which we didn't have before, because when we initially rolled this out, there were some resistance and barriers to actually being able to get the RCA done within 3 days, responding to the events no matter what time of day, figuring out who you could be in your pool of AOCs, of administrators and safety stop responders. And we worked all that out on the Tier 1 huddle and really used that as a way where we as a system could problem solve any barriers we had to implementing our standard work. As I mentioned, we have a system escalation huddle, which occurs twice weekly. This number is now well over 3,000. Again, a lot of the safety stops are for close call events. Only about 5% of the time are we doing a root cause analysis on these. We have trained 310 safety stop responders across our system to respond to safety stops. We've had a significant reduction in our serious safety event rate. Again, we started the implementation in January 2018 and finished in March 2019. This shows you the number of safety stops called, and you can see as we rolled it out, there were more and more safety stops called. The blue lines indicate, the red line indicates serious safety events. The blue lines indicate RCAs. So you can see that we have more RCAs than serious safety events, and that's because we, again, consider something red if it has a high likelihood of occurring or a high likelihood of causing harm. It does not have to cause harm. We have moved now to the point where about 50% of our RCAs across our system are for close calls, which is something we were very happy to see. We've done refreshes on our A3 that came out of the original work. We do it on a yearly basis, and we get feedback from everybody that's participating in a safety stop. And this word diagram at the bottom shows you that a significant awareness is something that people really have noticed, that we have awareness, transparency, visibility into a lot of processes that were broken as a result of our safety stop process. It also shows commitment, focus, and we have empowerment of our caregivers. We have, with our refresh, looked at next steps, and we still need to continue to work on repeat events. We need to do a better job of making our improvement work visible to the front line. And we, again, as I mentioned, we really need to make sure our other pathways for escalation are as effective as safety stop. Every time we have interviewed everybody involved in the safety stop, we've asked the question, do we really need both an administrator and a safety stop responder? Our safety stop responder pool is made up of our caregivers who work in quality, patient safety, risk, clinical education, lean, and we have had a lot of volunteers. We have data analysts who are sitting at home abstracting data who wanted to be part of this process, who have volunteered to be safety stop responders. We asked the question, do we really need both? And every time it's been affirmed how helpful it is to have a team that comes in to respond to the event. So some other successes is this has really prompted a lot of leadership rounding at the front line. We've embraced humble inquiry and using a coaching kata. It really has affirmed the escalation huddle work across the system. We've escalated 255 concerns, of which 232 have been addressed by system resources and closed. We have sharing of issues that are likely to be common across the system. And as we started to roll this out, people started to pull for it, for the safety stop process, which you'd rather have pull than push as you're rolling out a new process, with people saying, when do we get to go, when do we get to go? And that was just great to see. Education and training has been foundation. We want to have 16,000 problem solvers. So we have done an extensive amount of training on countermeasures, mistake proofing, what it really means to reliably implement and verify an action plan, on what standard work is and how you follow standard work, and how we do the closure process. Some key learnings, frontline engagement. There's been passion for this work. We recently just had a workshop in honor of Year of the Nurse to talk about what a PeaceHealth nurse is, and several of the RNs talked about how impactful and meaningful the safety stop process has been in their lives. We have an implementation call weekly. It's an oversight team that continues to do oversight on safety stop, and as I mentioned, what we're working on now is how we improve our other escalation pathways. Operational ownership has reduced a lot of overprocessing, and I also can't emphasize enough the importance of senior leadership in this. So we needed to have a senior leader, which we had in both our system CEO and system chief operating officer, to say that patient safety is your most important job. And when people would say, well, I'm an administrator on call, how can I possibly make time in my day for this, to stop what I'm doing and go help a caregiver with a safety event? The senior leadership would always say, if you can't stop what you're doing and do that, what else is it that you're doing that's more important than that? And that kind of, as the leader of this work, having that kind of backing from my system senior leaders was just very powerful and key in being able to roll this process out. The Stop the Line part has multiple benefits. Because we start the event investigation right away, we have evidence that is much more credible. We are now saving defective tools that otherwise we wouldn't have saved, so we know what the lot number is. We can then investigate it. We're doing interviews right away when the information is fresh. We were concerned about doing the RCA within 72 hours, about whether or not we would have enough information to do our timeline and do a credible RCA. But the fact that we respond immediately has made this very, very doable. We have re-engaged in lean, reduced our harm across the system. We have engaged senior leadership at the system level and also at the local levels with executive sponsors and senior leaders participating in this process. I've been in meetings with my chief executive and have gotten a safety stop call and said, I've got a safety stop call, and she says, go. So that's the kind of priority that we've placed on it. We adapted where necessary, again, to help make the process work for the critical access hospitals and the medical group. And we continue to make sure our documentation is up to date. We have a cadence that we update our standard work based on feedback in the spirit of continuous improvement, and we make sure that that is widely communicated and available. So, looks like we have a question.
All right, our final polling question. If you were to introduce a solution like Safety Stop, what would be your biggest barrier? And your options are A, we would have trouble getting strong or unified leadership commitment. B, we do not or could not agree on what problems we could focus on. C, we do not have capacity or a safety team or stability to lead this work. D, we do not have the resources, improvement specialists, or project managers to support this work. Or E, we already have a system like this. And once you have completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the CPE progress window to the right of the slide view. All right, let's go ahead and see what everyone has to say. Back to you.
So it looks like the major issue, which I agree is probably what most people see as the biggest barrier, is we would have trouble getting strong, unified leadership commitment. And so that is true for about a third. About a third already have a system like this, and I would love to learn from others of you about your system and how it works. We recently had a summit of organizations that came to PeaceHealth to learn about our Safety Stop process, and certainly they were concerned about getting the leadership commitment they needed. But we learned a lot from each other on what each of us is doing well and what each of us still has challenges.
Okay, thank you.
Back to you, Dahlia.
Thank you very much, Andrea. Deeply appreciative of our work together, and thank you so much for taking the time to share about PeaceHealth's story. So we're in our last segment here to talk about how we can keep patients safe at the forefront each and every day. And in the earlier poll questions, many of you indicated that you're surveying staff or LC have other practices in place to learn about safety culture. We know that healthcare team members are doing what they can and their very best amidst systems and processes that they have in place, but that we are challenged by interruptions and defects and workarounds. So this next section might seem like a refresher for some of you, but we hope that the information will either remind or inspire you to consider what else might be takeaways for you to look at within your organization to enhance your programs. So first, important to find and fix defects at the source or as close as to the point where they occur and not pass along defects to the next stop in the process. Work to create an environment that promotes and embraces speak up culture, including patients and staff, all members, so that we can surface problems and learn what improvement opportunities we have. And making improvement work visible is important, particularly in this day and age where we have a lot of electronic systems. It's hard to see what actually is occurring, so sometimes it's just really helpful to kind of flip chart or whiteboard what are the actions that we're taking to fix particular situations. I just want to touch upon a little bit more about safety culture, and sometimes we don't know about something because someone doesn't know if something is a big deal or not. We actually want to really encourage people to call those out and to share, because we will have a better understanding across the system of what is happening. And so put yourselves in the shoes of a patient. If you've been on the other side of having to disclose a particular situation where things broke down for a patient or their family, it is actually kind of a challenging situation. So as much as possible, we could try to put ourselves in the shoes of our patients and our families to think about what would they want us to be taking care of so that they can be assured that we're creating safe environments for them to receive care. The other part that is noted here is really a daily readiness approach, and thinking about how can you make sure that you have the systems and processes that people are ready to go for the day, that you're anticipating problems. What are the simple set of questions that will help you get ready and understand that? Making sure that you're looking to free up your time to go talk to patients, to really practice the humble inquiry, getting out there to understand what's happening. This is particularly important, especially with coronavirus, where we have an opportunity to really understand what our frontline caregivers need and what communication, standard work, job aids that they need to have in place so that they can move from a state of chaos to really a state of calm and comfort in this particular situation. And really think about whatever you can do to remove waste and really increase the value-added opportunities and processes to ensure patient care is safe, appropriate, timely, and compassionate are really steps in the right direction. It really takes all of us working together to prevent harm and to learn and support a safety culture. So that concludes our time today, and I think we will turn it back to you, Emily. Thank you very much for joining us.
We are just about out of time, so we won't be able to address attendee questions today. However, if you have a question for either of our presenters, you may still submit that in the Q&A window, or you may reach out to them directly through the speaker bio widget to the left of your screen. And thank you, Dahlia and Dr. Halliday, for a great presentation today. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts window to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate. A copy will be emailed within 3 weeks should you have any difficulty downloading it now. And here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.